Hello, welcome to Knowledge on the Go, the podcast brought to you by the Vizient Performance Improvement Collaboratives team. I'm Marilyn Sherrill, PI Program Director. Clinical documentation improvement, also known as clinical documentation integrity, is a topic that intrigues healthcare organizations. Strong CDI programs increase clinical and quality satisfaction for patients, more accurately track hospital-acquired conditions, and help maximize reimbursements from CMS. Michelle McCormick, Revenue Integrity Director, Clinical Documentation Integrity, and Mark LeBlanc, Manager Clinical Documentation Integrity, both from Stanford Health, developed a successful CDI program by fostering teamwork and simplifying the complexities of clinical documentation. Mark explains their approach.
I think prioritization is the key word here and a buzzword that we'll see in the CDI arena and in the profession currently as well into the future. We're all trying to figure out how to efficiently use the resources that we have to do the best work at the best time, and prioritizing that work, however you do it, is key. We work very hard behind the scenes on the system to set the prioritization or the DRGs that we want to prioritize and putting them higher up on the list so that the staff begins working from the top down. And then they continue to follow a case after they start it. Our prioritization not only helps us drive for new cases, but it also helps us to get away from the old CDI adage, you have to see a case every other day, no matter what. There are times that some of these cases don't need to be seen as often or even as many times as we used to think.
Prioritizing DRGs is a great way to promote daily CDI work. It also provides an organizational structure for the work and fosters relationships between physicians and the CDI team. When choosing DRGs to drill into, Michelle says, look for the unusual.
We'll take, for example, the Vizient reports where we look like we are an outlier in performance, either positive or negatively. We look at the negative ones first because those are the ones that come up as concerns. So if we identify a potential opportunity in Vizient, we'll pull data from other sources as well to look at that same DRG just to get a more global perspective on performance. Then we will push it through our formal process, which is our annual work optimization plan, and we'll do multidisciplinary reviews of those. I think CDI is the key to helping the organization understand outcomes, whether it's CC capture rate, length of stay, Vizient performance, or any of the other many performance metrics that we are using in healthcare today. Using DRGs as a way to identify potential opportunities has been really helpful for us.
By focusing on DRGs, the CDI team improves clarity within the reporting process, validates outcomes, and cuts down on extra work for everybody, something which resonates with Michelle.
I have found myself doing a lot of work trying to fix a problem and then later discovering that it wasn't actually a problem. It was just something else that's contributing to the variability in performance or discrepancy in performance. We've really tried to get as many folks engaged as we can in this CDI work, and that helps us partner in validating these outcomes. That was really the push for us to go to a more formalized process where we're really being proactive to identify these potential concerns before they rise up with our other partners. So with the C-suite, with the clinicians, with quality, and then always sharing that information with our partners. The key for us has been transparency.
Validating outcomes is really about getting people to not react, to try to minimize the reaction that people have to seeing reports. It's human nature when we see a report where we as the entity think, oh my God, we're missing something or we're not doing something right. And we all have to stop reacting and just go in and try to validate. It's a much better process, and we don't waste time trying to fix a problem that's not a problem or is not broken. We want to be transparent. We sit on committees, work internally together with our partners. We make sure that we are coming up with action plans. We set deadlines. It's going to take working across all spectrums of the organization as you find out stuff that needs to be addressed. Transparency helps to bring a light to the important work that's being done by CDI and coding for sure.
Transparency is shared with other teams and helps the CDI team get other perspectives on their data and how it shapes future improvement initiatives.
Some of the formal next steps after we complete a period of our work optimization plan reviews would be that our multidisciplinary leadership team would look at the results. That group consists of CDI leadership, coding leadership, and our medical director, who also participates in the reviews themselves. Then we share the opportunities that we've identified with our different committees. We may request or recommend that our quality folks do some additional analysis of these cases to look for practice opportunities or maybe some other issues or concerns that are outside of our scope. Also, we can identify other sometimes clinical practice trends that we think may be contributing to some of the outcomes as well. If we find opportunity trends, that helps us to focus our resources more effectively. And if that occurs, we provide education to our necessary teams, CDI and coding, physicians. We make necessary workflow, process, technology changes, and continue to monitor reviews through our work plan processes to ensure that the changes have been effective.
Michelle and Mark consistently look for feedback about the CDI coding process and any concerns from their physician partners. The insights shared with the CDI team led to important conversations and clarity.
We wanted to address some concerns from our providers that they felt like when they saw the data that gave them a response rate and an agree rate, they felt like we were nudging them or encouraging them to only agree with us. That didn't sit well with them. We just talked to them and said, what would make more sense? And they said, what is helpful for you and for coding? How do you define useful response? And we said, if you agree, we know how to apply a code to that scenario. If you say you're wrong and I disagree with you, we know what to do with that. If you give us a different diagnosis, we know what to do with the code. Those are all helpful responses. And that's how we came up with meaningful response rate to include agree, disagree, and any alternate or other diagnoses that they identify that's outside of what we were anticipating with the query.
I totally love the fact that it was driven by providers, conversations. You're going to get an overall response rate that's much higher when you have the buy-in and the understanding of why it's so important for them to just address the query and what things are going to be meaningful to us or to the organization.
Meaningful response rate leads to accessing more information from physicians with a lot less pushback. It also increases the trust between CDI team members and has other advantages.
It gave us a little bit more flexibility to make sure that the data output and the reports that we present to the providers on the queries are really much more meaningful and they're much more accurate. We can tell the providers how often they agreed or disagreed with sepsis without having this barrier where you have to, as a CDI, assign agree. There's this tension. If you put disagree, it means that something was wrong with the query, or maybe the providers didn't understand it. It really gives us a little more flexibility to be more strategic in being able to communicate what's really going on through the reports. It's definitely opened the door for us in acceptance of the data that we're giving to them, but also an example of us being true partners with them.
In the 4 years that I've been here, that engagement has just grown exponentially. They are tweaking the way that we apply the responses and making sure that we have the right query templates built into our system to create data that is useful.
Trying to do too much at one time with CDI is the norm in today's healthcare environment. Michelle has a perspective that might benefit others.
Everybody is super stressed. There's a lot going on. So take a big, deep breath and don't try to boil the ocean. Find one thing that resonates with you and that you think you can affect in terms of change in your organization and make it your own.
Thanks to Michelle and Mark for sharing their story and to you for listening to our podcast. We'd love to hear from you. Drop us a line at picollaboratives@vizientinc.com. From the PI Collaboratives team, I'm Marilyn Sherrill.